Frontal brain contusions are bruises of the frontal lobes of the brain, usually caused by head trauma such as road accidents, falls, or blunt injury. Because the frontal lobes sit close to rough bony surfaces inside the skull, they are commonly injured during acceleration or deceleration trauma. These contusions are often hemorrhagic, meaning there is bleeding inside the bruised brain tissue, and they can worsen over the first hours to days because of swelling, bleeding expansion, and secondary brain injury. The frontal lobes control judgment, behavior, personality, attention, planning, and movement, so survivors may later have memory problems, personality change, poor concentration, or weakness. In the ICU, the main goal is not only to treat the original injury, but to prevent secondary brain damage. This means avoiding low oxygen, low blood pressure, fever, seizures, high intracranial pressure, and abnormal carbon dioxide or sodium levels. Patients may need repeated CT scans, neurological examination, blood tests, neurosurgical review, and sometimes intracranial pressure monitoring. Severe TBI care often targets raised ICP because treating ICP above about 22 mm of mercury is recommended due to its association with increased mortality. The ventilator plays a very important role. It protects the airway, improves oxygen delivery, and allows controlled breathing. Carbon dioxide is especially important because it affects brain blood vessels. High CO can dilate brain vessels and raise intracranial pressure. Low CO from hyperventilation can narrow brain vessels and temporarily reduce ICP, but if taken too far it can reduce blood flow to the injured brain. For this reason, prolonged aggressive hyperventilation, especially PaR-CO of 25 mm of mercury or less, is not recommended. Short-term hyperventilation may be used only as a temporary rescue measure when ICP is dangerously high or herniation is suspected. Sodium management is also central in ICU care. Low sodium can worsen brain swelling, while controlled higher sodium levels may help pull water out of swollen brain tissue. This is where hyperosmolar therapy is used. Mannitol and hypertonic saline both create an osmotic gradient that reduces brain edema and lowers ICP. Mannitol is an osmotic diuretic, commonly used in doses around 0.25 to 1 g per kilogram for raised ICP, but it can cause dehydration, low blood pressure, kidney stress, and electrolyte problems, so blood pressure, urine output, kidney function, and serum osmolality must be monitored. 3% hypertonic saline is another major treatment. It increases serum sodium and osmolality, helping draw fluid out of the brain and supporting circulating volume. Current neurocritical care guidance suggests hypertonic sodium solutions over mannitol for initial management of elevated ICP or cerebral edema in TBI, although neither therapy has clearly proven better long-term neurological outcomes. Mannitol remains an effective alternative, especially when hypertonic saline is not suitable. Sedation and analgesia are essential. Pain, agitation, coughing, suctioning, and ventilator fighting can all raise ICP. Analgesics such as opioids and sedatives such as propofol or midazolam help reduce pain, oxygen consumption, co-production, and ICP spikes. However, oversedation can hide neurological changes and some drugs can lower blood pressure, reducing cerebral perfusion. Propofol can help control ICP, but high doses require caution because of serious complications. Barbiturates are not used routinely, but may be considered for refractory intracranial hypertension when standard medical and surgical measures fail. Neuromuscular blocking agents are not first-line routine therapy, but they can be useful in selected patients. They may help when coughing, shivering, severe ventilator dysynchrony, or procedures are causing dangerous ICP surges. But paralysis does not treat pain or anxiety, so deep sedation and analgesia must always be provided first. These drugs also hide seizures and neurological movement, and prolonged use can increase ICU weakness and pneumonia risk, so they should be used carefully and reassessed often. Corticosteroids have an important negative role. They are not recommended in traumatic brain injury. High-dose methylprednisolone was associated with increased mortality and is considered contraindicated in severe TBI. The large crash trial showed higher mortality with corticosteroids after head injury, so steroids should not be used to reduce ICP or improve outcome in traumatic brain contusions. Overall outcome depends on age, initial Glasgow Coma Scale, pupil response, contusion size, swelling, associated bleeding, hypoxia, hypertension, and speed of treatment. Mild isolated frontal contusions may recover well, but severe contusions requiring ICU care can lead to death or long-term disability. In severe head injury, only about 25% to 33% of patients may have good outcomes, and survivors may face cognitive, behavioral, physical, and emotional problems. Early ICU care, careful ventilation, ICP control, sodium management, pain control, and timely neurosurgical decisions can improve the chance of survival and recovery.